Well, thank you for having me here. So this is the diagram that Sudha had created on the different lenses and intersection where integrative mental health exists. So there's self-care, complementary alternative medicine, and then conventional psychiatry, and bringing it together to include lifestyle medicine and integrative psychiatry. So I was very inspired by Sudha's Venn diagram, and my whole talk today will be about the different lenses and viewpoints and perspectives that we have on the mind-body connection. So I wanted to start with my narrative journey first. And so I was born in Pennsylvania, but I grew up in Singapore. And Singapore is a melting pot of cultures, and so it taught me about lifestyle, culture, and upbringing, shaping an individual's life story. And then I went back to Pennsylvania, and there I worked at a Center for Integrative Medicine for the University of Pittsburgh Medical Center, and I learned that, it's more than just symptoms and diagnosis. It's really about expanding how we define illness and health and the self-care, so bringing that Venn diagram together. Then I went to Arizona for osteopathic medical school, where the tenets of osteopathic medicine is that the body is completely united. The person is fully integrated being of body, mind, and spirit. And that influenced my desire to talk to you about this subject today. And the body is capable of self-regulation, self-healing, and health maintenance. And structure and function are reciprocally interrelated. So then I went to Hawaii to complete my psychiatry residency, where I learned more about the different dimensions of whole person medicine and looking at the emotional and physical components. And then now I'm here in San Francisco, where I feel very grateful to be part of the Osher Center for Integrative Medicine, where we have a tribe of our integrative health community. And there's this inclusive nature of all kinds of healing paradigms, the diversity of healing paradigms that are out there. So again, I'm going to be looking at the different perspectives of the historical lens, how that influences our societal view on the mind-body connection or disconnection, also how that influences our support system lens and the medical team lens as well as the scientific lens. So looking at the historical lens first, I'm going to go kind of in chronological order. So in the Stone Age, they used skull trepanation, and that was for any behaviors that deviated from norms. So usually those were psychiatric, neurologic symptoms and also headaches. And they thought the cause was because there were evil spirits in the head. And so what they would do, they would drill a burr hole into the skull until the brain tissue showed. And that was a way they thought, to release evil spirits. So we actually still do this today. There's another term for it. It's called craniotomy, and that's to kind of help release blood that has pooled in the brain, and that's for what we call subdural and epidural hematomas. So then looking at ancient Greece, and you may have heard of the Hippocratic Oath. So Hippocrates is regarded as the father of modern medicine, and the Hippocratic Oath is a modified version, is still taken by all physicians today. So he proposed that there's a temperament of 4 humors, and Geronima Cortese last week had talked to us a little bit about this, but to reiterate her point, there was the blood, yellow bile, black bile, and phlegm, and they thought that blood was related to the season of spring and caused someone to be enthusiastic and social, whereas yellow bile caused someone to become more angry and impulsive. And today, maybe we could say that's a little bit towards the mania side. And then the phlegm was related to being apathetic, and black bile, black meaning this word of melancholic, so melon meaning black, could be related to being sad and depressed. And so this was the start of a reductionistic view, reducing complex states into more simpler physical terms. And there's a thought that there was a simple humoral imbalance that we were treating that led to these complex emotional causes, and that things should be treated with antidotes, so treatment of opposites. So if there was too much of the humors, they would deplete the humors, and they would use things like leeches for bloodletting or purging. And hot diseases like fever, they would treat it with cold medicines. So Hippocrates also coined this term hysteria. And hystera in Greek is Greek for uterus. And so some of the symptoms that they thought were related to hysteria was this excessive emotion conveying this sense of suffocation or distress. And maybe today we'd call it high anxiety, respiratory or intestinal distress. And this was the proposed cause, so that a dry uterus wanders in the body in search for moisture and pushes on body parts communicating distress. And the treatment was putting pleasant aromas in certain places versus also repelling aromas to put the uterus back in place. And it's thought that hysteria was one reason that women had few rights, because they were thought to have be unable to make a rational decision. So in the hundreds AD, there's Galen, and he's the physician of the Roman Empire and a loyalist of the theory of humors. And his specialty was dissecting illness of the body, and kind of it led to this compartmentalizing of an emotion. So he was a reductionist, and he was focused on separating organic versus non-organic. And his theories were actually the mainstay of Western medical science for 1,500 years, so they stayed for a long time. And so this is one case that Galen describes, this woman with insomnia. So just like today, he was ruling out causes of these humoral causes, and then he did a physical exam and noticed that when by chance he was mentioning this famous dancer's name, that this sudden irregular impulse would happen with this woman, and he thought it was a clue to the agitated mind. So his diagnosis was that this woman was in love with the dancer because it wouldn't flutter with other dancers that he mentioned. And he had this manual for treating psychological symptoms called On the Diagnosis and Cure of the Soul's Passion, and he suggested counseling patients to explore their deepest self, and this is an early form of psychotherapy. And so he also described 6 non-naturals, and these were thought to be outside of the body, not innate, and environmental factors that were involved in the preservation of health. So today we may call it self-care. And he thought that these were the 6 non-naturals: passions and emotions, air, motion and rest, which was including exercise, sleep and waking, things taken in by food or by drink, and evacuation and retention. And so he looked at this was the beginning of looking at the passions and emotions and their impact on physical health and illness. The Middle Ages, so mental illness was thought to be caused by curse, wrongdoing, or sin, and there are these supernatural theories of mental illness. So demonic possession, witchcraft, black magic, the evil eye, being cursed, religious punishment, and there are these rituals, including, you may recognize from the Stone Ages, the trephining with the hole into the skull to release evil spirits. There were exorcisms and magic spells and religious practices. So into the 18th century, mental illness was stigmatized, and that led to some of the asylums with no windows, being chained to beds, beaten, and with little contact with caregivers. And the focus was actually not for treatment, but to ostracize those with psychological disorders from society. In late 1700s, there was a French physician named Philippe Pinel, and he actually advocated for humane moral treatment. And so he thought that the asylum shouldn't be a prison, they should be a hospital, and unchained the patients so that they could leave. And he valued social interactions with the caregivers and also valued emotions. And so I also wanted to talk about the effect of some of the common 19th century treatments on the mind-body. So first being mercury, which they called calomel, and it was an antiseptic, diuretic, and laxative. But it had toxic effects on the body of blindness, memory loss, numbness, and seizures. And cocaine was a local anesthetic in lozenges and tooth drops. And it also was in Coca-Cola in the late 1800s. So there was this cola nuts plus the coca leaves. And you can see this ad here, tired, then drink Coca-Cola, it relieves exhaustion. And as a side note, lithium, its chemical compound is close to the weight of 7. And so it used to be put in 7-Up to increase energy. So yeah. And talking about morphine and heroin, so morphine was used to control cough and diarrhea and to soothe infants and children. So this Mrs. Winslow's soothing syrup had 65 milligrams of pure morphine per fluid ounce, which is quite a bit, yeah. And for heroin, it was used as a cough suppressant and marketed as this non-addictive substitute for morphine, and until it was banned in 1924. So therapeutic seizures, it's been one of our ways to address severe mental illness. And so in the 1500s, we used camphor to induce seizures and treat mental illness. And in the 1920s, insulin shock therapy was used to treat schizophrenia. So there was this purposeful injection of insulin to cause convulsions. And in 1938, this was the beginning of electroconvulsive therapy. And it's the use of electricity to induce a seizure, and it led to the first successful treatment of a patient with schizophrenia. Today, we still use electroconvulsive therapy as this reboot of brain chemistry, but it's under much more regulated conditions and not like the movies, like One Flew Over the Cuckoo's Nest. We use muscle relaxers, general anesthesia, and there's a very brief, low-intensity electrical pulse. So in the 1930s and 1950s, we had ice pick lobotomy, and this was surgery for the soul. And it was thought to stabilize intense emotions, including psychosis, depression, anxiety, and pain. And the procedure involved the doctor driving a slender instrument through the tear duct, hammering until breaking part of the skull to reveal the front part of the cortex. And this was called this revolutionary treatment, so much that the psychiatrist who had invented the procedure, Walter Freeman, won a Nobel Prize. So the procedure is phased out with the development of antipsychotic medications towards the 1950s. So now I want to talk more about the societal lens and how the historical lens influences the societal lens. And you may have heard this statement, mind over matter. It's to use willpower to overcome physical issues. And we start to think about how expression and recognition of mental health is shaped by our personal values and viewpoints. So, I can't say that I can speak to everyone's cultures, but I can speak to my own. So speaking to my own lens as an Asian American, there's a lot of social stigma and shame to those seeking behavioral health services. And there's also high emphasis on not shaming the family, bringing honor to the family. And so in some of at least the Chinese American culture, it's more likely that you're going to express mental illness through physical symptoms. So I'm going to go into the scientific lens now. So this is Descartes. He's credited for beginning the mind-body split, so dualism, in the 17th century. So he started talking about how body was like matter, and he called it res extensa, so because it took up space and it was non-thinking, and it's like furniture or these rocks here. And the brain is also considered physical matter, something that is tangible. So anything that was not tangible, he considered maybe part of the mind. This is a substance that thinks and is non-material, it's conscious, and it's this lever controlling the machine, which is the body, matter, including the brain. So looking deeper at the scientific lens, what we value as a scientist is evidence, facts, and that it's concrete, something tangible, objective, and looking at patterns and why do I see them so that I can come to a generalized conclusion. We also look at validity, so that a test measures what it's supposed to measure, reliability, so that you get the same results each time. But the mind is very unique and complex, and the experience of emotion and suffering is really unique to the individual. So that may not really fit well into the scientific lens. And so a scientist may call that unique, complex mind not tangible, difficult to pin down, outside of the box, and because of that, they may be thought to have non-valid underpinnings. And there's this risk of suggesting that a person is suffering emotional illness because they're feigning the illness, and it may actually influence the individuals, the patients, the caregivers, to seek extensive labs and imagings to find this root biological cause. So that all of this so far also influences the medical lens. So conventional medicine, or what we call mainstream medicine today, it really talks about the dominant health system based on culture and historical period. That's why I spent some time looking at the history. So it's medical interventions meeting accepted standards of care, and it's a training that's taught in U.S. medical schools and residency programs. And as you can see, there's been an evolution of what we consider conventional medicine. So today, what conventional medicine is regarded as biomedicine or Western medicine. And the 1910 Flexner Report was one thing that really drove the standardization of medical schools, and it called for strict adherence to evidence-based scientific studies. And so this led to valuing biomedicine or Western medicine over other modalities. And if we talk about mind-body dualism here, we have different specialties that also represent this. So, we have the general internist who study the body systems. We have a neurologist that studies the brain. And then we have psychiatry and psychology that studies the mind. So if a practitioner or patient thinks that there is this medical mimic or diagnosis of exclusion, they may consult the psychiatry team to evaluate for a psychosomatic disorder. Conversely, if a psychiatrist or therapist or patient or their supports thinks the presentation is organic or kind of like that body of matter, then that may lead to psychiatric workup where we review medications, check the blood, urine for the presence of drugs, substances, electrolyte or hormonal imbalances. And there's plus minus that we may consult the internal medicine or hospice team, and there's less stigma going this way. So I want to talk about why this is. So again, with reductionism in biomedicine, the body is felt to have concrete, tangible things that fit in a box. And there's actually some pros to this because it offers clear boundaries and certainty, and that's really good for acute life-threatening diseases. And so here's an example. If we had the concrete signs that you developed acute right lower abdomen pain and you had a fever, there's a high chance that you may have appendicitis, and that leads us to down the road of finding a specialist who I think you want a surgeon to operate on the appendix and perform the specialized treatment. So that's where it is good to have some boundaries and a focused lens. But that leads to any illness with poorly defined or abstract boundaries, such as many of the complex mind-body illnesses, to be kind of outcasted from this model. And again, risk of labeling illness as not real and feigned. So scope of practice also talks about our lens, and it can be organized by organ system or by stage of life. And there are times that you do want these expert-focused lenses. And so these are just some of the examples of all the different specialties out there. And conventional psychiatry today, there are a couple things that we do. The biopsychosocial formulation is part of every conventional psychiatrist plan, and it's unique to the individual. And we also look at labs and imaging to look at what are the organic illnesses versus psychiatric illnesses. And the psychiatric treatments involve medications or procedures that there's this presumed dysfunction at the level of neurotransmitters or brain circuits. And we also, part of conventional psychiatry also includes psychotherapy, and also some of the mind-body therapies. I think mindfulness now is very mainstream. And so I'm not going to go over too much of this, but just to show you all the different dimensions that a conventional psychiatrist may look at a patient with. So they try to look at the personal viewpoint of biological influences, psychological influences, and social influences. And they look at the timing of when they started, before kind of the illness, or were there stressors that caused the illness, or things that kept the illness going, or were there things that were more protective. And so 3 reasons why behavioral medicine is really uniquely situated to bridge biomedicine and be inclusive of an array of healing modalities is because there is a respect for the unique whole person, and again, use of the biopsychosocial formulation, an appreciation for healing that occurs on multiple levels, that it is bidirectional. The mind-body connection is bidirectional, and this emphasis on therapeutic alliance. So this partnership between the individual, but also all of the people who contribute to their care. And so I wanted to talk about the definition of integrative medicine. Everybody has their own lens on what they call integrative medicine, but to me, this is my definition. An approach to healing that explores the whole person, including individual values and lifestyle, while making use of all appropriate and evidence-informed therapeutic modalities, healthcare professionals, and disciplines to promote optimal well-being. And you may have heard this term, the integrated care model, and this is what we may call medical home. So it's patient-centered care. It's collaborative with a treatment team, and it involves usually the primary care physician, but also where a behavioral health specialist will be in the same center, and there may be this central care coordinator. And the goals are to improve access to care, support the continuity of care, lead to preventive strategies, and promote education amongst the providers, and hopefully lessen the stigma associated with mental illness, because patients may be presenting at the primary care doctor as opposed to going to the psychiatrist. So I want to just differentiate that from integrative care, where we still use many of the collaborative treatment model things, but it can represent a diverse array of healing modalities. And then there's also other terms of holistic medicine, complementary medicine, functional medicine, alternative medicine. I'll talk about that in a moment. So you can see with the evolving terminology of the National Institutes of Health, we can see this kind of change in the acceptance of integrative medicine. So there used to be, in 1991, they started with the Office of Alternative Medicine, and alternative medicine means in place of conventional medicine. Then they changed their name to the National Center for Complementary and Alternative Medicine in 1998. And so complementary medicine means together with conventional medicine. And finally, fairly recently, it's now the National Center for Complementary and Integrative Health. And that was in 2014, and it describes integrative medicine, which is complementary alternative medicine, but together with the coordination of providers. And with the NCAM classification, they had 5 domains of how they wanted to sort the healing paradigm. So less conventional biological, mind-body, somatic or manipulative, like massage, energy therapies, and whole medical systems or traditional medicine, like traditional Chinese medicine or Ayurveda. So since 2014, with the change of their name, they just now have 2 groups, and it's natural products or mind and body practices. I think it is to recognize that there are many overlaps. So looking at complementary health approaches more, the National Health Interview Survey is an annual survey that's given to 30,000 households. But every 5 years, they have questions about complementary health approaches. And pretty consistently, it shows that 1/3 of the US adults use a complementary health approach every year. And if we just look at mind-body practices, these are the most common ones that come up. So yoga, chiropractic or osteopathic manipulation, meditation, and massage therapy. And then there was a study that looked at the 2007 results. It actually takes some time before the study comes out, so it came out in 2013. But it looked at patients with neuropsychiatric symptoms. and how often they were using complementary alternative medicine. And it showed that 43.8% versus 29.7% were using CAM approaches. And the more neuropsychiatric symptoms you had, the more likely you were to use CAM and most common mind-body medicine. And a lot were using CAM because standard treatments were too expensive or ineffective, and also because it was recommended by the conventional provider. So I want to focus a little bit more on the term mind-body. And so here we see it separate again, kind of like Descartes, with the mind and then the brain and body. And so this is what we call dualism, two separate entities. And this is what the biomedical model usually uses, a dualism specialization approach. But if we look at the connection, there's something called non-duality, where the mind and body are actually inseparable. And that's more often used in a model of looking at someone from the whole person perspective. And so some of the phrases, I know Geronima also talked about these, but these are phrases that express anxiety, elation, surprise, and they clue into this mind-gut-brain connection. So a gut-wrenching experience, a pit in my stomach, or butterflies in my stomach, or I've got a gut feeling, like an intuition about it. I wanted to talk about this hydra. So this was a primitive marine animal with a floating digestive tube that was surrounded by a nerve net. And there are some theories about how this being came to be. So algae in the ocean settled inside the digestive system of the hydra, and it's thought that microbes started living inside the system and using their own form of communication that was developed for 4 billion years in the oceans and producing these neuroactive substances like things that are related to serotonin or GABA. And the microbes then started to communicate with the nerve cells of the hydra. And so this is a fairly recent article that was actually published in 2018, talking a little bit more about how the hydra was one of the representations that leads us to believe that this separate brain system is inside the gut, called the enteric nervous system. And so the enteric nervous system, it's the mind of its own. It's neurons lining the gut that has its own reflexes and senses, and this unique ability to function independently from the central nervous system. The vagus nerve is what we think of when we think about resting and digesting. And actually, vagus nerve stimulation is one treatment for depression. And gut bacteria, probiotics, produce and respond to the same neurotransmitters that the brain uses to regulate mood and cognition. So GABA, which is a calming chemical, serotonin, which is also calming, norepinephrine, which is related to kind of your fight or flight system and anxiety and pain, dopamine, your kind of motivation hormone, acetylcholine, memory, and melatonin, which is derived from serotonin to help you with sleep. The gut actually makes 3/4 of our neurotransmitters, and 95% of serotonin is found in the gut. So that's why when we talk about side effects of antidepressants, some of the side effects are gastrointestinal distress because it's affecting the serotonin in the gut. And if we look at the bidirectional communication, we all know that gastrointestinal distress sometimes can lead to anxiety and depression. And conversely, stress, anxiety, depression can affect the movement and contractions of the GI tract. So in a biomedical model, a lot of my training as a psychiatrist was differential diagnosis and fitting things in a box from our diagnostic Bible called the DSM. And it was the search for organic or physical root causes and differentiating them from psychiatric. So some of the examples that are part of the anxiety differential are usually things that involve kind of the fight or flight system. So stimulants, if you have a withdrawal from something that is usually calming, your hormone system, which is involved with the stress response, and anything you can think of that can cause like the anxiety attack, those systems are also involved. So for example, like breathing usually gets faster, and we think of pulmonary embolisms or hyperventilations or cardiac arrhythmias. And the differential for depression is pretty much anything that affects sleep fatigue, or leads to a drop in function. So any kind of stimulant withdrawal, some of the autoimmune diseases where your body's attacking itself, or infections, and some hormonal diseases, and certain medications can also be associated with depression. So I want to come back to hysteria. So in this little newspaper clipping, it says, crying, sobbing, laughing. She has no control over herself. So this is questioning the validity of hysteria as a real disease. And there's this thought that the individual may be mimicking symptoms of other more definable diseases. And then it became this umbrella term for less definable illnesses. So I wanted to talk more about the evolution of terms of what we now call functional neurological symptom disorder, and this is based on the recent Diagnostic Statistical Manual, which we use in psychiatry. So in the 17th century, Thomas Sydenham was a British physician known for writing the standard textbook of medicine at that time, and he started to question if hysteria was actually a disorder of the brain and nervous system. Sigmund Freud, you may have heard of him. He is this Austrian neurologist and known as the father of psychoanalysis, and he hypothesized that an unconscious, unresolved mental conflict converted into body symptoms or physical symptoms and classified this phenomenon as conversion disorder. It wasn't until 1980 that this diagnosis of hysterical neurosis conversion type was replaced with just conversion disorder. And it was defined as a mental condition in which signs and symptoms affecting voluntary motor or sensory function could not be explained by a general medical condition. So again, pushing things outside of the box because it's too complex. And so in a biomedical framework, the diagnosis required confirmation by a neurologist that this presentation was indeed non-organic. And so now, again, it's called functional neurological symptom disorder. And actually, the DSM still has conversion disorder in parentheses. And it's thought to, some of the signs are a sudden loss of sensory or motor function. And this is when the consult liaison team, which is the hospital psychiatry team, may be very busy ruling out psychosomatic illnesses, which are said to be not explainable medically. Some of the risk factors for functional neurological symptom disorder are trauma, and it may have this symbolic meaning. So for example, if the patient saw a husband cheating, that may lead to the sudden blindness. And it's typically, they've typically seen someone with the illness. And it may be related to a difficulty using words to describe emotions. So what happens is the body becomes their language and communicates for them. And so I look at this as a term that one of my other dear mentors, Dr. Peng, had told me about called emotional constipation. And the treatment for emotional constipation is learning ways to invite or express emotions versus rejecting them. So some of the biomedical tests that have looked at ruling in, ruling out conversion disorder are, for example, the psychogenic non-epileptic seizures. It used to be called pseudo-seizures, but that implies that the patient is feigning symptoms. So now it's called psychogenic non-epileptic seizures. So they'll look for an absence of some of the labs that are associated with seizures and also the brain activity. And we can look for weakness by an arm drop test. So you kind of just have the patient drop their arm, and usually if someone's not conscious of it, they will hit their head. But if they are, it may be a conversion disorder, it may avoid their head. And for blindness, we use an optical kinetic drum test. And deafness, you may ask, can you hear me? And they say no. Yeah. So looking at the personal lens, your personal lens is your assumptive world, and it's your unique viewpoint of self-experiences. And we know that our individual thoughts and ideas influence behaviors and actions. And there's a very personal way of experiencing emotions and sensations that we can try to explain to others, but it's very still deeply rooted in us. And our lens assigns valence, so if things are positive versus negative. So in cognitive behavioral therapy, one of the things that it looks at is cognitive distortion. And this is why I also wanted to use the analogy of the lens. So these cognitive distortions can influence depression. And so if you're magnifying worst case scenarios, that's like catastrophizing. If you're minimizing positive details, that's discounting the positive. If you're wearing polarized filters or colors, that can kind of change your perception of the world. So if it's only one color, it's overgeneralization. If it's only black and white, it's all or nothing thinking. And labeling is kind of things like saying that you're a failure. Or is there a special power to the lens? Can you see into the future, or fortune telling? Or can you read the mind of others, or mind reading? Or if you see it in your lens, you think it must be true. That's similar to emotional reasoning, where I feel it, therefore it must be true. Or is there this custom-made lens just for you, and that's a cognitive distortion of personalization or blame. So talking about the support system lens. So thinking about how does someone relate to our personal lens. It's really our human nature to look for patterns or relationships. So if you have this lens, you can notice it's a different shape lens and color and fit. And so there's a low chance for this lens to really see your point of view. And there runs this risk for the people around you to label you as other, and a risk for a stigmatized or marginalized view. If you have this aviator lens, it's a different color, but it's a similar fit, and there may be a greater chance to relating to your viewpoint and more empathy and connection with you. And so how do you communicate your personal experiences of illnesses? Is it by finding shared features? Like our glasses all have gradients of color, and it can be similar to saying we have all gone through a grieving process. Oh, so I wanted to talk about how I am linked to Northern California. So even when I was growing up in Singapore, and every single year we would come to Yosemite National Park. My father has been going for 40 years straight, and this is a picture of Tuolumne Meadows. It's one of my favorite places. In fact, I wrote about it in my medical school statement and also my personal statement for residency. And this is me in Yosemite a long time ago. I still have the same haircut, I just realized that. And, and this is the tree that grows out of the rock. So I think this is a good analogy of resilience and expecting things to grow out of rocks, which is not expected. And I wanted to talk about growing together with this tree, Yosemite Park, and my family. So this is me, probably in 5th grade, and my dad used this tree as a yardstick of our growth. And so that's my dad and me later on, and you can see the tree is also grown a little bit, and finally you can see the tree's grown a little bit more there. So it's towards the entrance of Yosemite Park, but it is something that has been very meaningful in my own journey. And so if we think about what constitutes healthy growth and relationships, we may be thinking about individualization in this society where we should be separating from early relationships. It's usually more of a Western theme that promotes growth into an independent, self-reliant individual and respects a lot of autonomy and self-fulfillment as benchmarks for growth and relationships. And then Sudha talked to me about the relational cultural theory. She introduced this to me, and I thought it was like this braided money tree, where there's periods of connection and then also disconnection. And the times that you're disconnected, there may be suffering, fear, and vulnerability, but it pushes you to desire reconnection, and it creates these opportunities for growth, for being mutually impacted by each other, and also developing your empathy, sensitivity to the impact of your actions onto others, and lastly, authenticity in relationships, sharing your inner experiences, thoughts, and feelings, which may actually promote other people to share that kind of level of authenticity in return. So lastly, I want to talk about mirror neurons. This is your special empathy lens, and Marco Icobani, in his book Mirroring People, had this great quote: by helping us recognize the actions of other people, mirror neurons also help us to recognize and understand the deepest motives behind these actions, the intentions of the other individuals. So I noticed just now when I was talking about the ice pick lobotomy, I heard a lot of gasps in the audience, and that's probably because you have this mirror neuron and you can kind of feel what that person may have gone through. So suffering and pain through facial expressions. And when we think about relating to fictional characters, either through movies or books, that's also where our mirror neurons can work, or watching movement. So if someone picks up a cup, you can kind of intimately know what they're going through. So now I want to talk about gradients of trauma and suffering. And so I had started the course with this model of stress, which was designed to protect us from danger, leading to 3 automatic stress responses. So either moving towards the danger, so fight response, freezing at the sight of danger, or moving away from danger, so flight. And long-term, this can lead to it becoming a stressor and many of our life challenges. So that's the theme of our course. And I want to talk more about gradients of trauma or stressors and say that it's really specific to the individual's lens of suffering. So usually when we think about PTSD or post-traumatic stress disorder, we think of war veterans and those who have gone through things that are unspeakable of physical, sexual, emotional abuse, neglect, or abandonment. But suffering is really personal to the individual. So that can be related to common stressors, life challenges, or any kind of transitions you're going through, any kind of injury or grief, or even a change in your identity or your role. So even a diagnosis of an illness, I'm seeing it as trauma, or a fear of recurrence of illness, a fear of recurrence of cancer, or losing a job. Losing a loved one, including if they have memory issues with aging, and that's kind of changing their personality and cognition. And so to diagnose post-traumatic stress disorder, I have this mnemonic. There's a stressor, and some of the symptoms are reactivity and hyperarousal, avoidance, intrusion symptoms like flashbacks and nightmares, and negative mood and cognition. So the mnemonic I have is RAIN for 1 month or more. And so I was inspired here to talk about the work of Gabor Mate, and he has this book called When the Body Says No, Exploring the Stress-Disease Connection. He really focuses on adverse childhood experiences. In our psychiatry world, this may be related to Bowlby's attachment theory. And he uses this word of approximate separation, leading to how we develop our patterns of self-soothing. So if the parent is physically present but emotionally absent, either they have, you can see here, anxiety, or they're avoidant, or they're just going through their own stressors. It's really nothing bad on the parents. They're going through their own stressors themselves, but they may not be as available to connect with the child. So the key here is the child's perspective on their attachment to the parent. So even if we think that the child had a stereotypically good childhood, and the child may conjure up this maladaptive thought that if I show my emotions, it only adds to my parent's load. And they may suppress their own needs or emotions that are needed to maintain the attachment relationship with the parent. And with these emotional needs unfulfilled, that can lead to that term again by Tracy Peng, emotional constipation. And so I have this diagram, or this picture here of thinking of the oxygen mask. When you're flying, you're supposed to put your oxygen mask before you help your child. But in this case, I'm looking at it as the child helping the parent put on their oxygen mask and kind of focusing on that. So if this becomes lifelong, where this individual learns to express high concern for the emotional needs of others while suppressing their own needs, this person may value this push-through mentality, duty and self-sacrifice, and where that is really valued is in helping and healing professions. So they may have a lot of positive reinforcement to keep doing this push-through mentality and maintaining a sense of duty and self-sacrifice. And so a form of addiction that can happen, we can call it workaholism, to kind of fulfill these values that they've developed. And if someone keeps suppressing their needs, they may not notice at first because there are these stress adrenaline patterns that gives you energy and helps you push through. But I don't know if you've ever noticed this, but once you rest, all these neglected needs surface again, and this may be like getting sick again after a stressful project is finally complete. And so one of Gabor Mate's thoughts is illness one way that the body signals that emotional needs are neglected? Is it a wake-up call? And is it supposed to be the language to help us think about what we need to change in our behavior? So Gabor Mate also talks about trauma and addiction as ways to kind of soothe distress, soothe pain, or escape from distress. So if you think about the substances involved in soothing pain, opiates soothe both emotional and physical pain. Cocaine and alcohol are local anesthetics, so numbing agents. And if we look at the brain when someone is emotionally rejected, it's the same parts of the brain light up as if you had struck them with a knife. And so we could be using some of the addictive substances out there to also motivate action. Right? So stimulants motivate action. And then these are two examples of this infant monkey separated from their mothers, which inhibits dopamine in the part that of the brain that leads to decision making. And then in maternal depression, increase of the stress hormone, leading to potential attention issues in the child. So how do we heal emotional constipation? And I've said this before, it's our natural nature to try to reject things. You know, if you value push through or self-sacrifice, to reject the emotions. But learning to invite the feelings instead, and it's akin to mindfulness tenets of presence, being attuned to your body cues, being non-judgmental and compassionate of yourself, and being open and aware. So now I want to talk about integrative therapies for trauma. And this bowl here is a form of Japanese ceramic art. It's called kintsugi. And I found it very interesting because with the broken bowl, they're using gold alloy to mend and also even highlight the cracks of this broken bowl. And so when we think about the deepest, darkest life challenges, how do we deepen our capacity to live life fully? And I like this quote by Abigail Adams. It's not in the still calm of life or the repose of a Pacific station that great characters are formed. The habits of a vigorous mind are formed in contending with difficulties. So again, it's the theme of our mini med school of embracing life challenges and finding balance. So. Lastly, I want to talk about the neurobiology of healing trauma with integrative modalities. And I'm drawing this analogy as inspired by Dr. van der Kolk's book, The Body Keeps the Score, which I highly recommend. There are three parts of the brain that I'll be talking about: the prefrontal cortex, the amygdala, and the thalamus. So the thalamus is where your sensory input comes in, and it has two jobs. It either filters that sensory input, or it mixes the sensory input. So when it filters out irrelevant input, if you have a problem with that, that can lead to this constant sensory overload where you can't shut down. And it usually functions to stir up sensory input into this integrated, coherent soup. So if you have an issue there, that can lead to these isolated sensory fragments that we see in trauma. So from that point, the stimuli usually takes two pathways. It can either go to your primitive emotional brain or your amygdala. And because we're looking at this like a smoke alarm, to decide if there really is a threat there. It has first dibs on, it's a quicker pathway from the thalamus to amygdala. And the other pathway is the medial prefrontal cortex, and this takes several milliseconds longer. So to talk about the amygdala, the analogy that Dr. van der Kolk uses is that is like a smoke alarm. So it's evaluating if the threat is, if the incoming stimuli is a threat to our survival. And it elicits the help of the hypothalamus, which is related to fight, flight, and freeze, and also pushes out our stress and adrenaline hormones. But once the danger has passed, usually the body gets back to its normal state. It also talks to your memory center to relate new input to past experiences. And in trauma, you may have an overactive smoke alarm. So it's kind of like a hyperactive alarm system, and it may misinterpret whether the situation is dangerous or safe. And this leads to potential prolonged startle or aggressive outbursts, and someone may use substances to kind of numb strong sensations. And then the medial prefrontal cortex is what we call a watchtower. And it's your rational conscious brain. It's directly above your eyes, so it gives you the big picture view. And it refines your interpretation of what's going on before reacting. And so as long as you're not too upset, its job is to help you realize that the threat is a false alarm. So for example, oh, actually my house is not on fire. The smoke alarm went off because I'm cooking. But in trauma, there's theories that the medial prefrontal cortex is not active as much as it should be, and that's why this emergency hyperactive amygdala emergency response system dominates and becomes more difficult to control emotions and impulses. So how do we address this? There's what we call bottom-up and top-down approaches. So bottom-up, it's usually accessing like your breathing or your heart rate, the things that relate to your autonomic nervous system, and it integrates breath, movement, and touch. So some of the examples are yoga, dancing, playing music, and body work. And we also have to strengthen our prefrontal cortex so that it is a watchtower that is calmly, objectively looking over our thoughts. And breathing actually hits both of these because it's under involuntary and voluntary control. So how do we tone down the hyperactive amygdala? We can use a bottom-up approach where we recalibrate this autonomic nervous system. And again, it's back to the basics of breath, movement, and touch. And the goal is so that your smoke alarm, it's still there, but it's just no longer falsely reactive and kind of going on all day long, you know, that it appropriately defends against danger and it helps you take care of your body the way it should. And these are some examples of toning down the hyperactive amygdala through a bottom-up approach that involves breathing and movement. So meditation, yoga, dancing and expressive movement therapy, martial arts, capoeira, tai chi, qigong, drumming, chanting, and even choral singing. Yoga and chanting and choral singing is maybe part of yoga and some religious practices. So biofeedback is another way. Biofeedback is a way to monitor our psychophysiological changes, like your heart rate, breathing patterns, your carbon dioxide, your skin temperature, how much you're sweating, and your muscle tension. And by concretely seeing it on the screen, you can get a better picture of what your body's like automatic responses are and develop the skill to address stress in a different way. And we actually have a biofeedback practitioner at the Osher Center, Dr. Chris Gilbert, who works on this approach. So touch, it's a natural way for humans to calm down in distressing a situation, and it reduces excessive arousal. We can think of our natural inclination to hug a friend when they're distressed. And body work is part of this category, including massage, craniosacral therapy. And this is another way to tap into the amygdala. Sensory integration clinics where children may dive into tubs filled with all these different colors and tactile things that they can touch. And how do we strengthen the hypoactive prefrontal cortex? We can use what's called a top-down approach, where it is the prefrontal cortex is hovering calmly and objectively over our thoughts, so that we allow the time to kind of modulate those hardwired, primitive, emotional, automatic reactions. And it's actually a prerequisite for safely revisiting trauma, to learn to observe and tolerate your physical reactions. And strengthening the watchtower's ability to monitor sensations may promote a sense of autonomy, improves your self-awareness and your view of yourself, and tuning attention towards your thoughts, emotions, and physical sensations in a more detailed way. So this is an example of mindfulness, meditation, and yoga. Of first allowing your mind to focus on sensations, and then notice that in contrast to that ever-present experience of trauma with the intrusion and flashbacks, that physical sensations are transient, and there are slight shifts in your body, your position, your breathing patterns. And so we may think that we can apply this to shifts in our thinking, that our thinking can be transient. And the next step would be labeling the physical sensation. So when I feel anxious, I feel a crushing sensation in my chest, and noticing how that sensation changes when you're taking a deep breath in and out. So again, breathing is under both conscious and autonomic or involuntary control. So this is a video from the University of Wisconsin Integrative Medicine Program, which is a large part of our training in the fellowship at the Osher Center. And I want you to look at all of these almonds at once, and I'm wondering, what do you see? Anyone? Is it moving? It's moving, yeah, it's like little waves, right? So now I want you to just focus on one almond and see what happens. It stops, yeah. So this is kind of an example of using mindfulness, and I just thought it was a nice one, yeah. So lastly, repairing the thalamus. So we talked about the thalamus being our filter and also our mixer. And so in trauma, if you have deficits there, the individual may be engulfed by these sensory emotional elements of their past, and the trauma kind of has its life of its own, because the person may not be able to avoid sensory overload or kind of integrate the fragments of like flashbacks or nightmares. And so how do we reprocess trauma in a safe way so that trauma isn't dominating our life, and we can see like the rest of the landscape there, so we can put trauma back in its proper place in the overall arc of life? So this is one way, the eye movement desensitization and reprocessing therapy. It's thought to work on the thalamus. So there's this bilateral sensory input. It can be side-to-side movements, but it's different than hypnosis. You know, it may be side-to-side movements like this, and the therapist may use like a wand to go back and forth, or touch your thighs like back and forth like this. Or there can be kind of two wooden sticks that you would hold that kind of create electrical impulses. So it's theorized to be associated with rapid eye movement sleep, where our eyes go back and forth. That's why it's called rapid eye movement. And the thought that dreaming forges new relationships of unrelated memories. So it's thought that EMDR, or the eye movement desensitization reprocessing therapy, is a way to kind of shake up your relationships, like your deep connections to the normal pathways of trauma, and put the traumatic experience into the larger context, so you can gain some perspective. And in this way, there's usually no need to reverbalize the trauma as well, and so it avoids re-traumatization. So again, we've talked about some bottom-up approaches and also some top-down approaches here. And breathing hits both of them. And so I just want to say, with loving kindness, thank you for sharing your lens with me. And I have many people to thank. So my dear patients, you, the audience, Sudha, of course, and many of my mentors at the UCSF Osher Center for Integrative Medicine. And also at the Osher Mini Medical School, Nancy, and our IT team, and definitely, again, the audience. And then Chelsea helped bridge the link between Osher Mini Medical School with Sudha and I. And Silver Quevedo, who was a veteran of the Osher Center, also speaking with us. And we've also appreciated David Lukoff and Geronima Cortese and Jim Duffy. And I also want to thank my faculty attendings and co-residents when I was attending University of Hawaii's psychiatry residency program, and my fellow colleagues at the UPMC Center for Integrative Medicine and the medical students, faculty and preceptors that were involved in the Arizona College of Osteopathic Medicine, the dynamic evolution of conventional medical care and integrative health, my family and friends, and of course my life challenges and joys. And so these are some of the resources that I referenced in today's talk, and I think, except for the life after the diagnosis, which I think is a really good book on looking at having a diagnosis being kind of like traumatic process and how to work with that. And it's actually written by Dr. Pantalat, who is here at UCSF. And I want to also say that all of these slides are available on the website, including all of our speakers' slides. So you can access it there. And at this point, I want to invite Sudha up here. Yeah. Mm-hmm. Thank you. And we just want to end by talking about some of the resources at the Osher Center for Integrative Medicine. So this is our website, osher.ucsf.edu. And that's our center. That's in the Mount Zion campus. That is near, like on Divisadero and Post Street by Japantown area. And these are some of the values that the Osher Center embodies: whole person care, equity, compassion, collaboration, focus on wellness and empowerment that really drew me to the Osher Center. And here are kind of a little sampling of all the services that we have on our fourth floor, which is our clinic floor. So integrative medicine consultation, integrative cancer care, integrative psychiatry and psychotherapy, integrative peds, integrative women's health, manual medicine, and spinal manipulation, biofeedback, traditional Chinese medicine, Ayurveda, including Sudha, and integrative nutrition, guided imagery, cognitive behavioral therapy for insomnia, and massage therapy. And so I wanted to talk a little bit more about our integrative psychiatry team, including Sudha and Tracy Peng. So we're board-certified psychiatric doctors that are trained in conventional and complementary medicine. And these are some of the benefits of treatment that you can find on our website. So in order to make an appointment, the first step starts usually with a phone interview to kind of see what are your pressing needs and how we can best serve you. And this is the number 415-353-7700. And so some of our, the benefits of integrative mental health treatment are really tailoring our treatment plan to the individual. And this can include any of the following. So exploration into the interaction of the mind, body, and spirit and your environment, and accessing your own intuitive capacities to guide your life. Conventional medications, we still prescribe that, along with supplements, botanicals, and herbal remedies. Conventional psychotherapies, including cognitive behavioral therapy, psychodynamic or insight-oriented therapy, dream work, symbology, and I do a lot of motivational interviewing as well. And expressive creative arts therapy, meditation, mindfulness, guided imagery, visualization, and relaxation. I also do pharmacogenomic testing, especially for patients which I feel like have a lot of drugs, potential drug-herbal interactions going on. And Sudha also does Ayurvedic massage, nutritional counseling, yoga and movement exercises, and mandala drawing. And our goal is really to create this integrative plan so that we can discuss what are the buffet of options that best suit your needs and collaborate with your treatment team. So lastly, I want to talk about the public classes that we have available at the Osher Center. And that includes even like laughter yoga and the mindfulness-based stress reduction class. And of course, you are part of the Osher Mini Med School for the public class. And we're part of a network of integrative medicine enthusiasts. So this is the Osher Collaborative for Integrative Medicine, and it comprises of this international group of 7 academic centers funded by Bernard Osher, that's why we call it the Osher Mini Med School, to study, teach, and practice integrative medicine. So I feel very proud that we just celebrated almost our 20th anniversary at the UCSF Osher Center for Integrative Medicine. And then in 2001, Harvard came along. Then 2005, the Karolinska Institute in Sweden. 2014, Vanderbilt and Northwestern. 2017, University of Miami. And then finally, the newest addition is University of Washington. And these are some resources. I like natural medicines because it's a way to look at complementary alternative therapies and see what the level of evidence is for them, but also to look at drug interactions with conventional medicines and herbal remedies. If you're at UCSF, it's part of the library database. And I had referenced the National Institute of Health National Center for Complementary and Integrative Health here. And this is also a good resource, their Office of Dietary Supplements. And so that's it.
Thank you, Selena. Wonderful closing talk. That was a huge overview of our whole course, actually, and many of the topics we covered. I do want to say before we move into the question phase, a lot of you were interested after the first session I had given on Ayurveda. You had contacted me about the Ayurveda group treatment that we were considering starting at the Osher Center, as well as individual Ayurveda consultations. I just wanted to let those folks know that that's definitely happening. So we're going to be doing that starting in July. So if any of you are interested in that group therapy or in the individual consultations, I know some of you had already contacted me, but if there are others who haven't yet, please do so, and I'll get back to you with some additional information about that. And that's a great question. The question was, why did we not cover hypnotherapy? There's just a range of complementary therapies that we just obviously can't cover every single one. There's literally hundreds of them. But actually, hypnotherapy has a very special place in the realm of integrative psychiatry because it was one of the very first therapies that was considered like a complementary treatment that like Freud and Breuer and some of the very early psychiatrists actually use that particular therapy to access the unconscious. And I'm actually trained in hypnotherapy, and we actually use it quite a bit in hospital consultation psychiatry. So when we are working with patients that are in the ICU or that are recovering from chemotherapy or have chronic pain syndromes, it's a very, very effective modality that we can use to actually help lower pain or make people more comfortable. And there's a lot of data behind it, actually, so it's one of the best researched areas. So thank you for bringing that up. Okay, so if I could rephrase your question then about, you're sort of bringing up the idea of computers and the use of technology really becoming dominant in healthcare, and whether we see that as a threat or in some ways going against some of the principles of integrative medicine. Would that capture your question? Okay. Do you want to tackle that?
Sure. I think with the advent of even the electronic medical record, it's actually been very helpful to coordinate with different providers, and that's one of the aspects of integrative medicine. Having said that, I think a lot of the providers out there have been really sucked into looking at the computer screens, so that can detract from the presence with the patient. There are some other ways that technology can be helpful. There's this virtual reality exposure therapy that I have seen with even with a smartphone that's helping patients with like a fear of heights or social anxiety disorder. And I just learned of these Google glasses that are out there for patients with autism that help them recognize some of the social cues out there. So in that way, I do think that some of the technologies can be helpful. Having said that, I also wonder if it's decreasing our ability to connect human to human, that interface. Mm-hmm.
Yeah, and I think, in fact, the advent of technological medicine or high-tech medicine towards the late 70s, that was really one of the impetuses in this country for people going back to an earlier model, like earlier traditions, indigenous healing traditions, looking for healing paradigms from other parts of the world or from other parts of culture that had been essentially evicted from Western biomedical model by the Flexner report and by the heavy push for a science-based curriculum that dominated in the early 20th century. So I think as high-tech medicine started to be recognized as not always being successful as sometimes failing human beings. The case of Karen Ann Quinlan in the late 70s was really a kind of benchmark for, I think, the public perception of high-tech medicine really having drawbacks to it. This was a young woman who was basically kept on life support despite basically being brain dead and being in a vegetative state. And her family was fighting to disconnect her from life support so that she could essentially die with dignity. And at that time, the hospital system that Karen Ann was hospitalized in were concerned that that would go against their Hippocratic oath and would go against the idea of doing their utmost to save her life. So it became a sort of battle between the high-tech medical specialists and then her family that really wanted her to be able to die at home surrounded by loved ones and not by machinery, and really having a rite of passage, having a right to a death with dignity. And I think that really highlights some of the underlying, I think, ethical and humanistic concerns that are embedded in that question that you've asked. And I think that integrative medicine, it wasn't a coincidence that all of, like Andrew Weil, Deepak Chopra, some of the pioneers in integrative medicine really rose to prominence in the late 70s, early 80s, in part because people were having a second look at high tech and really wondering, is this really everything that it's cracked up to be, or are there some drawbacks? And so integrative medicine was really a way of taking a step back and taking a bigger perspective. And some of those alternate healing paradigms that had been sort of tossed out in the early 20th century by the Flexner Report, people started coming back and looking at them and saying, hey, what about Chinese medicine? What about yoga? What about meditation? Is there something about this approach to healing that will help us reconnect with these humanistic aspects that are getting lost in a very, very technologically driven medical model?
So the question is about physical manifestations that you may see with trauma. So a lot of the things that are related to your stress response system, including like your increased heart rate or gastrointestinal system, and that slide that I had on the differential of anxiety, I view trauma as a spectrum of anxiety. So you may see a lot of those physical symptoms. So I may bring back that slide if you'd like. Yeah. Mm-hmm. Okay, so this slide here is some of the physical manifestations that can come with anxiety. So addressing your hormone systems and things that relate to your heart systems and lung systems. Mm-hmm. Does that answer your question? Or?
Okay, I've got a couple of ideas about that. I think that what Selena had put up is like a really important slide. Actually, I think the one after that, the brain gut response, yeah. Maybe. Like, for example, she's talking about how the enteric nervous system actually contains like a lot of the receptors for neurotransmitters in our body. And I'm really struck, I've been working with, within the realm of post-traumatic stress disorder, I've done a lot of work with sexual assault survivors and survivors of childhood sexual abuse. And I'm often struck by the fact that unexplained abdominal pain or chronic pelvic pain is a very common manifestation of people that have gone through those particular types of traumatic sequela. And yet when we do a medical workup, we can't find a specific cause for that unexplained pelvic pain. And so then in the past, we used to say, well, this is a psychosomatic, it might have been dismissed as a psychosomatic manifestation of the stress or the trauma that they've gone through. But now we have these like very interesting emerging fields showing how much of, our serotonin system, for example, lives in our gut. And so the person is perhaps expressing, that sexual trauma that they have gone through through an unexplained abdominal pain, which in the past could have been seen as not really being related to the psychological trauma that they've gone through. But now there's a really nice emerging explanatory model for why that might actually be getting triggered, in terms of the pelvic pain. Now, of course, I'm not trying to dismiss that there's also a lot of symbolic value, obviously, in something like that, because the physical, in terms of the body keeps a score, like the body remembers at some level, like where the injury occurred. And in terms of sexual trauma, it's not, a hard leap to make in terms of why symbolically there might be pain in the pelvic region and so on. But I'm just like really struck by how much as this emerging neurological model tells us about where additional sources of pain and stress could be manifest. This could be one of those. Another way that I see post-traumatic stress disorder as having physical sequela, we were talking earlier on about how much is emerging in terms of chromosomal changes, genetic changes that happen as a result of chronic stress. So, telomerase gets shorter and shorter, which means that the cell's ability to repair itself and be able to heal and be resilient in the face of, stress and stress hormones becomes less and less. And so when that happens, basically the body continues to break down. Cellular mechanisms break down. So with post-traumatic stress disorder, we often see people that, look 10, 20, 30 years older than someone else of that same biological age. And I've often wondered, what is the explanation for that? And now I think we have a much better idea of some of those cellular mechanisms, of repair and the immune system effects of chronic stress, which really mitigate against those self-healing aspects of our own system.
And I just wanted to add this example of conversion disorder or functional neurological symptom disorder as a physical manifestation of trauma. And so one of our main treatments for things like the psychogenic non-epileptic seizure is psychotherapy to address the trauma. So this is what Sudha was just talking about, that trauma may have a symbolic meaning. So some people that saw their husband cheating, it can lead to that sudden blindness. So it has a deep impact on the body. Yeah, so the question is about severe levels of psychiatric distress and trauma and how we may apply that in an integrative model. And to answer your question, I think it really starts with the whole definition of integrative medicine to me is really focusing on the individual's narrative and starting to carefully kind of unpeel the layers as they will allow, and looking at that patient's personal values, how that was shaped, and what are their, in this story that was told about the adoptive parents and the child bonding from this child that was in an orphanage in Romania. So looking at both of their narratives together. So what integrative medicine means to me, at least, is really just tuning into the individual's story and their lens. Mm-hmm. Well, I think we have a lot of really exciting developing programs at the Osher Center that we welcome you to see. There's a lot of classes out there, but in terms of this privilege to share this course with you, it's been wonderful working with my mentor, Sudha, here. And we will be speaking at the American Psychiatric Association on holistic approaches to treat PTSD. And there's an integrative mental health conference that's coming from the University of Arizona on the 15th to 17th of this month at the Hilton SF that you can start exploring some of the integrative mental health approaches, but we also welcome you to talk to us directly and kind of learn about your specific interests. Yeah. Mm-hmm. So the question was about using psychedelic treatments for like PTSD or trauma. And we had a great talk, our second session, by Silver Quevedo, who is running some of the phase 3 trials looking at MDMA as a psychedelic to address trauma, and it's specifically opening kind of the landscape so that trauma isn't so sticky in its ingrained patterns. So I definitely see potential there, but because we live in a conventional medical model, we need to have like studies to back up these things coming into mainstream medicine. So that's kind of where it is right now, but looking at the potential for helping out, it could be helpful. Mm-hmm.
So like that study that Dr. Quevedo was talking about is actually still in the phase 3 trial, which means it's not yet FDA approved. So until it becomes an FDA approved treatment, we're probably not going to be offering it at the Osher Center. But in the future, why not? Yes, if it becomes approved, absolutely, it could be incorporated. That's a great question. So the question has to do with context in which a patient might feign symptoms and what might be going on with them on a psychological level to motivate that kind of behavior. This is actually a perfect question for what we call psychiatry consult liaison, and that's the field that I'm actually in. So we consult a lot at San Francisco General Hospital. That's actually one of the places where I work, and there's a whole way of looking at individuals that may have symptoms that are being fabricated, essentially. So one, we have to differentiate between like three different reasons for that. So one is just what we call malingering, which is what a lot of people unfortunately lump all of the people that might feign symptoms into this category. So malingering means that you're consciously making up that symptom for what we call secondary gain, which means for like a very specific benefit, like getting SSI, like being able to collect disability income, or being able to get out of being drafted into the Army, or some such thing. So there's a very clear-cut reason that doesn't have to do with being ill per se, but there's a secondary benefit of being ill that you're trying to benefit from. But that's actually not as common as you might think. There's a couple of other reasons, though, that people might feign illness from a psychological standpoint, which I think are actually more interesting. And one of them has to do with what we call like factitious disorder. I was trying to think about another, like a more common language sort of way of doing that. But the idea with factitious disorder is that you may be aware consciously that you're feigning the symptom, but you are not actually clear on why. The actual reason for it might be unconscious. And this is a very, very large segment, a surprisingly large segment of people that come into the general hospital setting who might feign illness. They're not actually malingering. They might know when they're confronted that they're actually feigning the symptom, but they cannot tell you actually why they're doing that. And that often has to do then with helping them to understand unconscious motivations. So for example, we had a patient who came in to San Francisco General, and she was actually injecting bacteria into her bloodstream so that she was getting septicemia, and she was having all of these, blood cultures showing positive for infection. She would get treated, she would go home in pretty good shape, and then come back again, in a month with, a different strain of bacteria in her blood. She was finally caught injecting this material on the inpatient unit, so we were able to actually work with her on understanding what was going on. And she said, I know that I shouldn't be doing this, but I just can't help it. I just want to keep doing this. And so we basically were able to tease out, after a lot of working with her on the inpatient unit, that her mother had apparently died of her mother when she was a very young child. Her mother had died at when she was age 10. When the patient was age 10, the mother had died after getting a puncture wound, some sort of nail or something that she had stepped on, that she didn't get treated. She eventually ended up becoming very septic and dying. And the patient didn't actually know at the time what exactly was going on, because everyone was trying to protect her and didn't tell her why the mom had died, but she had somehow picked up that there was something to do with an infection in the blood, and she was very, very heartbroken as a young child, didn't really understand why it was happening, but why it had happened, why her mother was gone. No one actually wanted to get into the details of it because they thought they were protecting her. But in the end, it actually sort of backfired, because she had this feeling, and her mother was a particular age when she died. I think her mother was 37 when she died, and this patient started injecting her stool like at age 37. And she had never never made that connection before. Like, why? Why was this happening now? So this is just like an example of factitious disorder, because she knew she was doing it, and she couldn't really explain why. And it took a lot of teasing apart, using psychotherapy to actually help her understand how she was actually coping with the loss of her mother and feeling that she herself should die at age 37 because her mother hadn't lived beyond 37. And so it was somehow like a survivor guilt that she was actually getting, to a point that where she might exceed the age of her mother. That's just a little glimpse into that. Yes, it is very difficult because, as I said, many people confuse malingering with this kind of unconscious desire to fabricate symptoms or feign symptoms.
So I think we're out of time right now, and we welcome some individual questions, but we really, really want to thank you for joining us this whole course. Yeah. Thank you.